Hey y'all, it's me, Dr. Smita Rahman, Gyno Girl. I'm super excited today to be on this podcast with the amazing Dr. Mary Claire Haber. I'll do it like Oprah. Um, she is, most everyone knows her. She is a board certified OB-GYN and a certified culinary medicine specialist from the American College of Culinary Medicine. She's a Louisiana State University Medical Center graduate and completed her OB-GYN residency at the University of Texas medical branch. She's also a certified menopause specialist through the Menopause Society. She was a clinical professor at UTMB and the University of Texas Health Center in Houston for a very long time. She has now amassed over 5 million followers through all her social media platforms and understands that menopause healthcare is in dire need of change. She's here to demystify and change the narrative around menopause. She's also a New York Times best-selling author for her amazing book, The New Menopause. Woohoo! So awesome. So if I had an audience, I'd have them all clap for you to welcome you to Gyno Girl Presents Sex, Drugs, and Hormones. I'm super excited that you're here today, Marie Claire. I love everything you're doing, and I love being part of the menopause with you. So thank you for joining me.
Mm-hmm. Oh, I'm so happy to be here, especially with another member of the menopause. When I tell you, it is so wonderful to have this community of like-minded providers from diverse backgrounds, all focused on changing the narrative and the woman's healthcare prospects about her, the last third of her life. It just means everything to me.
Absolutely. And I really I have to commend you so much because, we have obviously a lot in common. We're both OB-GYNs. We both, are from the South. I started my own practice about 10 years ago. And at that time I was trying to talk about, genital urinary syndrome, menopause and everything, but it never really picked up the momentum. And I just really love what you've done. You've really spearheaded this movement, honestly. You've amassed so many people following you. I mean, just tell my listeners, because I'm going to talk to you about your menopause story too, but just tell my listeners how, 5 million followers over so many social media platforms. You've just done such an amazing job of reaching out to people, right? I think when we talk about really making a change in people's lives as doctors, we tend to do it on a one-on-one basis, but to do it on such a global level is really just wow. And so I commend you for that, number one, but tell us how you came to this and how it happened.
I mean, I wish I could tell you that there was this grand Machiavellian plan to take over the menopause space. But, my daughter is interning for a menopause telemedicine company right now in their marketing and PR departments. So she's having to do a, breakdown of what's working in the menopause world. And she #menopause and she's studying everything. She's like, Mom, the post, she goes, you're one of the people that's getting a lot of the menopause tags. I'm like, okay, yeah, all right. And she said, but it's they're you entertain and then you educate and you advocate and you validate. And I go, that's about it. I've gotten good at listening to people on social media, getting curious about what they were complaining about, digging through the research, educating them about it, and then making them feel like they were normal and then giving them tools on how to manage it. And so that's what the book is a compilation of all of that I've been doing on social media for years.
That's amazing. And the book is amazing. I'm sure most of my listeners have it by now, but because I talk about it all the time. But I want to say the other day I was at this function for Liberty Road. Have you heard of Nada Jones? And she's started this sort of group where she talks to a lot of midlife women on the middle third of their life and changing their narratives and everything. And, one of the topics that just kept coming up about midlife women is how much noise there is out there, right? There's a lot of noise on social media. There's a lot of discussion around, wellness for the midlife woman, trying to navigate that. And some of the people there were like, sometimes I just get frustrated and I don't know how to navigate this. And they just walk away and they don't do anything about it. But for the people listening, what advice do you have for them to how to navigate through all this noise? Because obviously when something has gotten to this kind of force, people are trying to monetize off of it. And we know that midlife women are in a vulnerable situation where they often get
there's
vulnerable. So much predatory work.
So if I had it,
so it's
I'm seeing it just as you are with so much, people trying to take advantage of the confusion and the misunderstanding. And, so here's what I would go back and tell my 35-year-old self who was looking forward at menopause as this kind of scary, weird thing that would make me an old woman, that I wouldn't be expected to thrive, and that I would probably not have any hot flashes because I was thin. That's what I really thought. So,
Right.
number one, educate yourself about menopause. This is coming. It's inevitable. It's a way bigger deal than we thought, and it's going to affect you in ways you never imagined. And so as much as you can do, my book, other people's books, podcasts, whatever, to make sure that you know what's going on, you understand the basic endocrinology of it, and that how it can affect different organ systems is only going to make this less scary and therefore lower your cortisol levels through this process. Number two, nutrition over calories. Like, many of us are so motivated to be thin, be thin, be thin. And everything I ate was to be skinny, and everything I moved my body exercise was to be skinny for 25 years. And that was a mistake. And so learning about muscle fitness, health, wellness, eating more protein, eating good nutrients, trying to change your habits so that it is supporting you to be a healthy old lady is very, very different than what it looks like in your 20s. And so the things that we get away with. And so starting those habits now. Really think of aging as a privilege that is denied to so many of us, and that this can be the best part of your life. Literally, I am living my best life. Like, if you would have told me, I am healthier, I am wealthier, I have better connections with my family, I have better boundaries, I have better, I'm helping more people, I've reached, 5 million people. And all of that is just, I want that for everyone so that they can look at me at 56 and say, I have charted a course for the best third of my life. Like, this is it. This is my time. I got this covered, rather than being plagued with poor health and frailty and cognition trouble and not being able to keep your job and then suffering from the fallout, the financial issues from that.
No, absolutely. And you and I know that, when we graduated residency, I want to just talk about how both of us came to the menopause space and our journeys in this space as of now. But we both know that we didn't get much menopause training in residency. Like, that was like, I think I saw, like, I had an REI doc that showed me a couple menopausal patients. And I remember I was an intern when the WHI came out. I remember the journal club around it, and we were like, well, why are they making such a big deal of it? It doesn't seem like it's like, not that big of a deal about this breast cancer increase. And, we were like very baffled by sort of like the media noise around it. But the reality is, most OB-GYNs don't get the training. Most PCPs don't, most internists. I think, what is the statistic? 7% of graduating residents out of those three professions have an idea of how to take care of menopause.
Feel competent. Yeah.
Feel confident, right?
Yeah.
So let's talk about how
here's what scares me is that when I finished my residency, I felt like I was a great menopause. That's the problem. I didn't know what I didn't know. And so what I'm hoping all this noise we're making is to have clinicians realize, something ain't right.
Yeah.
But they are saying, well, how much menopause training did I actually get? So.
Right. No, it's true. It's true. So what did you, how did you come to your journey through menopause, and what did you feel when you were
sadly, it was my own menopause. And rather than, I was aging with my patients. So I kind of stayed in the same practice for most of my career. And you start out, you're having babies, they're having babies. That was kind of the path. And then I was aging with everyone. Certainly I had menopausal patients before, but I was getting a bigger percentage of my patient population as menopausal. And I was seeing the same things, like weight gain, not sleeping, depression, anxiety, like all these things these were like women I was in the community with. I went to church with them. Kids went to school together. I worked out with them. And they're all like, what the hell is happening to me? And I started realizing, is this menopause? Is this part of it? This was never taught to me. And then I got the rug pulled out from under me. It was horrible because I was on birth control, got off, and figured out I was immediately menopausal somewhere. I had gone through menopause probably at 48 and had no idea. And so I didn't have a transition. I just woke up, it's like coming off of therapy, and was like, this is for the birds. I can't function. And wait, I felt like I was throwing in the towel by going to HRT, like the epidural, oh, I'll see how I do. was my attitude about an
Yeah.
epidural. And I got one at 3 centimeters because I was dying. So, but then I felt like a failure. You kind of like, oh, I'm not tough enough or I'm not strong enough. And that I realized that is faulty mentality. Then as I started digging,
Yeah.
I was learning about the cardioprotective benefits and the neuroprotective benefits and and
Right.
what the actual risk of osteoporotic fracture is and what that will do to a woman. And I was like, wait a minute. And sexual
Mhm.
dysfunction and genital urinary syndrome and all the things. I was like, what are we doing? We're ending up with an aging population of women who are miserable by and
Miserable.
large and can't take care of themselves and are needing long-term care
Yeah.
facilities and suffering years and years of disability when they don't have to.
Yeah. Right. Right. Absolutely. I mean, it's so interesting how, like, I think when at the menopause conference last year, Sue Dominance was talking about how she came up with her article about, misled about menopause in the New York Times. And she said that, one of the underlying themes she kept hearing was that, like, women had just come accustomed to suffering. And as a society, we're accustomed to women suffering, right? Like, we've just accepted it. I mean, how many times do you have a patient who's told you that when she complained about something, a doctor told her that, this is just what women have to do, or, like, you need to
Mhm.
try X, Y, or Z, drink alcohol, whatever, do something that you, you just the underlying tone is that, like, your body was made to suffer, and it just shocks me that, like, we accept this as a society, right?
Mhm. Yeah, it is
Uh,
100% the biggest crock of shit that has ever been fed to women. And, we don't have to. You want to suffer, that's your jam, go for it, but you don't have to.
right.
And we
Yep.
have ways to mitigate this suffering where you can be a fully functional, you know, able to give everything you've got to the world, human being, with some intervention. And suffering is not acceptable.
Absolutely. And it's funny because, as OB-GYNs, do we not hear about, like, these stories all the time? Well, when I remember when I was pregnant, they were like, well, when I was pregnant, I was contracting while I was delivering someone. Like, it was a badge of honor to suffer. You know what I'm saying? Like, we just
Oh
perpetuate it,
yeah.
right?
Or to labor in the middle of laboring a patient. I mean, that was,
Yeah. Yeah.
I
I remember
finished my
complaining to
L&D
patients.
shift and laid down in the bed and had a baby. Like,
Yeah. Exactly. And it's supposed to be like, oh, you're a badass because you suffered through it. Like, no, it's not okay. Like, we shouldn't, like, reward that. I mean, if that's something you really want, that's up to you. But there are options to not do that too. So
yeah.
I think that's
Yeah.
something I'm glad that narrative is sort of changing now too. Tell me about your journey. Like, when you came, like, you decided to, like, because I actually, true fact, I used to follow you way back in the day when you were just, like, doing the
Galveston
Galveston diet
diet.
and all that stuff. And I used to,
Yeah.
yeah, would order your fiber, and I'm like, "This is the best fiber in the world. I love it." It was really
Tripping
good.
right
I
now.
was like, there you go. And the collagen, and I haven't looked at your turmeric yet, but, I, uh, I was like, "Oh, this Dr. Mary Claire, she's onto something," like, I remember, like, looking at your recipes online. But tell me how you came to culinary medicine. That's very amazing
Yeah.
too. Like, that's pretty cool.
So my kind of toe in the water here in the menopause space was, my like what brought me to the trough. And this is embarrassing, but damn true. And most of my patients complain of this was my weight gain. And I was
Mm.
so frustrated with the weight gain with menopause because remember, my social currency, how I felt about myself every day was based on that number on the scale. And it's an embarrassing thing to say. I was an almond mom, whole 9 yards. I'd had thin privilege my whole life, but it was work, and all of a
Yeah,
sudden the work wasn't working. And I was like,
exactly.
I was getting obsessed, weighing myself multiple times a day, doing 2 a days in the gym, starving myself, and it was not working. And, I was
Yeah.
that whole like calories in, calories out. Like, what? Am I crazy? And my husband was like, girl, first of all, my teenage daughters were watching all this like disruptive
Yeah,
behavior.
I know.
And
I have the same experience.
and he's like, no, 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 you look great. Like, he's like, you're beautiful. I don't care. Da, da, da,
Yeah.
And
Yeah.
then that motivated me to look outside the box. Okay. And then I called the PhD nutritionist at the university I was at. I was like, what the hell is going on in menopause? And they started sending me
Mm.
articles about inflammation and nutrition and estrogen's role in anti-inflammation and how it's all connected and visceral
Mm.
fat. I knew nothing about visceral fat. And then like
Yes.
Pandora's box opened for me. And so I start
Yeah.
sharing about that part of it, create a little nutrition program for my patients and myself. It's going well. Start sharing that on social. Galveston Diet explodes. I make a book, I make a program out of it. But then as I'm conversing about nutrition and menopause, people are asking, what, menopause? What about frozen shoulder? What about my this? What about my that? And that's where the conversation
Yeah.
got bigger and bigger. And so I decided I don't want to be in this box of a diet doctor. Like, the nutrition culinary medicine certification was to give me credentials and learn, because they didn't teach us anything in med school. And it was awesome. And I highly recommend it. But I knew that my mission was bigger. Like, I'd conquered the nutrition thing. Now I want to like take on all of menopause. And so that's where I just broadened my conversation online and was sharing everything I would learn. And so that resonated with people, and it just kept growing.
Oh, that's great. Yeah. And I think one of the big things, that we all need to just accept is that we do have a genetic impact on how we age and everything like that, but it doesn't have to own us, right? Like I think that's the one big thing that I've come to realize, is that I have very bad genetics when it comes to cardiovascular. I mean, I'm South Asian. We have like
Cancer.
such high rates of cardiovascular disease. Yeah. And so like, I feel like I'm constantly fighting my genetics. Like I'm just like, but I'm not going to just lay down and let it happen to me either. So I think that's an important message you always say too, right?
Right. I mean, genetics is a loaded gun, and then our lifestyle is what tends to pull the trigger. I mean, again, that's kind of a blanket statement, but if we go with the status quo of what Western medicine is really offering women right now as we age, you are going to die of a heart attack way before me, and I'm going to get cancer way before you. And we're not willing to accept that. And so we are trying to use every tool in the toolkit to put those odds back in our favor. And menopause is a huge part of both of those things,
Absolutely. Let's talk about your toolkit. Actually, I love that, in your book, you talk about a little bit. I mean, basically you give like a whole toolkit for all the, issues surrounding menopause, and tell the listeners about this toolkit that we have here. And also your website.
So the toolkit theory is that, health it's not in a vacuum. So it's not like I'd give my patients HRT and send them out the door, right? We're plotting a course for the next 30 years, and it includes nutrition, exercise, stress reduction, sleep optimization, supplementation, whatever. Okay. And that looks different for every patient. It really is precision medicine. So the toolkit was a way to approach each symptom in menopause, not just the hot flashes. I'm talking the brain fog, the musculoskeletal disorders, the skin changes, the hair, nails, gut, everything. And what do we know that nutrition does? Like, what specific nutrients might be helpful here? What supplements have been shown to be helpful? What exercise tends to work better here? If you have these certain things, so that a woman felt empowered, and that you realize it's not just HRT. That's just one small part of your toolkit, if you even choose it. It's not for everyone, but that we have all these other things, other pharmacology that might be helpful outside of HRT. And so I just wanted her to have as much information to advocate for herself, because I can't be everyone's doctor. And, so that she could have, at least on her end, an informed decision, informed choice on the future of her health.
I think all those are important, and just understanding that it's not, everyone always says, oh, you menopause doctors are just pushing, hormone therapy on everyone and this and that. And it's not. It's like, we just want to destigmatize hormone therapy because of the, WHI. Everyone knows that. Yeah. And so, we want to destigmatize, but we also want to just like, give everyone the tools they need. You're right. Absolutely. I think that's a great combination of things that you've given. When we talk about this menopause like movement that's happening right now, there are a lot of new tech companies that have come up, right? Like, where do you think that intersects with what we're doing as like on the ground clinicians?
So I think the best of two areas I see where we can intervene, where I'm excited. One is in testing and doing more, figuring out ways to diagnose perimenopause out, because we don't have a great blood urine or saliva test for that. And people are spending thousands of dollars on unnecessary testing. And so really putting some data and science behind how are we going to diagnose perimenopause, even that's with some kind of a continuous monitor, or, what that's going to look like. So that's one area. The other is there's a couple of pretty good biotech companies, at least two, if not 3, that are figuring out ways to extend the shelf life of the ovary beyond, what we're genetically programmed to be. So using AMH derivatives, anti-Müllerian hormone derivatives, to slow down the aging of the ovaries, because our ovaries age twice as fast as any other organ in our body, and therefore we become menopausal. And so could we extend that shelf life, not for reproduction, but just enough estrogen being produced to keep us healthy, to not live with the estrogen deprivation syndrome that affects our liver and our bones and our general nervous system. So I'm really excited about that.
Yeah, I think that's what I'm waiting to see, like what comes out of that, because because we all know when patients enter menopause too early, it's such a dramatic health risk. Can you talk to the viewers about that?
Yeah. So
Entering
the
menopause.
longer our bodies are forced to live without estrogen, the less healthy you are on multiple cardiometabolic and neuro disease states. And so in premature menopause or premature, that's 40 to 45, that's early menopause, they have risks. So the longer your body is forced to live without estrogen, the higher your risk of cardiovascular disease, diabetes, stroke, hypertension, osteoporosis, et cetera. So then when you get into the premature ovarian failure, premature ovarian insufficiency years, it's even worse. Surgical menopause is worse, and so those things aren't being addressed. So iatrogenic surgical menopause, for good reasons, but then no one's addressing their health risks as we age. The studies are coming out just showing that, it is criminal what is happening to women who go into early menopause for whatever reason, especially surgical, that are not being counseled adequately or treated so that they can optimize their health. Ovaries need to be removed sometimes for disease, and we need to do that. But then they're just being thrown out into the wind as menopausal humans, being forced to live not 30, 50 years, 40 years without the benefit of estrogen, which speeds up this race. It speeds up their aging in every other organ. So now they're dying earlier of stroke, diabetes, hypertension, dementia, Alzheimer's.
Yeah, and
it's less to do with putting labels on. It's everything to do with how long your body lives without estrogen.
Absolutely, absolutely, because it's such an important hormone for us. And how do you see some of the other, so there's a lot of platforms that are now coming out when we talk about tech. There's all the good menopause platforms.
Telemedicine.
Some clinicians, telemedicine. Some of them really get threatened by them, but I'm always like, are you going to be able to treat this billion women that are going to be in menopause?
So
there's an access issue, right?
Study came out in 2023, and we've seen the data of self-reported residents saying, I don't feel comfortable. So we only have 7% graduating today who feel competent, whatever that means. Okay. When a woman in 2023 walked into her doctor's office and complained of the cliche menopause symptoms, so God forbid she didn't have hot flashes and had palpitations or something else, she has no periods and hot flashes. It is undeniable she's menopausal. She only has a 10% chance of being offered any treatment at all. 90% of clinicians will deny her anything. Just say this is normal. There's nothing we can do. Bye-bye. Of the 10% who are offering her something, 4 to 1, it is an antidepressant. This is the problem. So savvy tech companies see this need, understand these statistics, and know that women are needing help. They are developing telemedicine companies specific to take care of this need. Look, I have a waiting list of 2 years for menopause, and this is cash. This is not insurance. I can't afford to run a practice with insurance because I don't do surgery anymore, which would pay the bills. And so there is a need. I don't know why they're getting upset, because we cannot handle the menopause burden. We don't have enough providers.
No, absolutely. And, when we talk about, these telemedicine companies, I mean, some of them are really practicing amazing medicine, and
some are not.
Yeah. Yeah. So you have to do your research and try to get under that. And so I think it's one of these things where it's even direct to consumer marketing, right? Those some of the direct to consumer products that are out there, a lot of people are threatened to buy. But again, we don't have the capacity to treat all these patients. So I think that it's actually a good thing the majority of the time. Tell me, what do you think? Because obviously you do a deep dive into every potential symptom of menopause. What do you think is the weirdest symptom you've ever heard of for menopause?
Oh, the ones that blow up the internet are, at least on my stuff, are the frozen shoulder. Right. People go nuts over frozen shoulder. Vonda Wright has built an empire off of frozen shoulder, on the internet, because
Absolutely.
she's probably the world expert in musculoskeletal syndrome of menopause. It's amazing. I think tinnitus and vertigo, vertigo and the ringing in the ears, that people are like, holy shit, itchy ears, that drives people crazy.
Years ago, I had a patient with severe vertigo, and I was like, well, I mean, you need hormones. Let's try it. And I did a deep dive, and I saw it. She's like, but Dr. Mike, this is a miracle. Because the vertigo is very debilitating. It's really.
Mm-hmm.
Oh, yeah, you said itchy ear, too. Right?
The taste stuff. So change in taste, change in smell, change in taste, the burning tongue syndrome, that those really get people's attention, because they were dismissed and told there's nothing we can do, or put some capsaicin on your tongue, which is peppers, which does seem to work a little bit for burning tongue, but it's or just HRT, or to the poor woman who presents to the ER with palpitations, sweating, anxiety, and gets a full cardiac workup, all this stuff. And literally she was menopausal. That's all it was, and no one being trained to connect the dots there for her. And she goes to multiple doctors for multiple problems, ends up on polypharmacy, when all that probably would have taken care of 90% of it was replacing her hormones.
Absolutely. I have to say, my husband's a physiatrist, so he does PM&R, but he does interventional pain sports medicine. And he's always sending me patients with joint pain. He was like, I'll do the injection, but I think she's perimenopausal. Or the frozen shoulder thing. Yeah. So it's very interesting. Yeah, I think that whole finding has been very transformative for patients to realize, when I wake up and I can't walk, or, not being able to lift your shoulder above a certain point, it's pretty amazing, actually, that the hormones can make that much of a difference. So what do you think some of the biggest myths that we still should bust? I mean, I'm busting myths all the time around here, but, with WHI stuff and everything else. But, you never can
that hormones are dangerous. That hormones are dangerous. One very popular gynecologist said, and this one I was like, why would she even do that? But okay. That somehow you're less if you're not taking hormones. That those of us who have open discussions about hormone therapy are considering that women who don't choose HRT are less of a woman, or something like that. I think that kind of talk is just harmful and not helpful, especially coming from a clinician in this space with a big following. Bioidentical and synthetic and all the misinformation. That pellets are the way to go. I think that's a big misunderstanding. I think you have better options out there for your hormone therapy, and probably much less expensive and incredibly efficacious and safe. That is not the way to go.
That a load of testosterone, they're going to feel amazing, but is it safe for you in the long run?
It's temporary. So there's a certain company that makes a certain brand of injectable pellet, what we call pellets, which are little dissolvable tubes that have a medicine embedded in it. And so I don't want to demonize a pellet. It's just one way to put stuff in your body. But this certain company never made a female dose. And so to treat females, they give them the lowest male dose, which gets a woman physiologically typically above 200, in nanogram per picoliter, whatever the measurement scale is. And, a female level is 45 to 70 is healthy, young 25-year-old female. And so they're super physiologically dosing routinely every single woman. So they get this initial burst and they turn into teenage boys. They feel great. Their libido's restored, yada, yada, yada. But then, the higher you go, the more side effects you have. And then it stops working. You develop tachyphylaxis. And so, I think you have better options, and there's no reason to go super physiologic on a patient that we know of that would be at all beneficial. So you could get her libido, working back in the right direction. You can get her bone and muscle moving back in the right direction with the resistance training and the protein intake, with physiologic female doses, without the barrage of side effects that we see at the higher doses.
Absolutely. I mean, we all understand why this industry of bioidentical marketing existed, because nobody was giving women the hormones. So obviously
it's our fault.
Oh, no, absolutely. So, I mean, that's why I don't villainize patients who go that route, because I'm like, well,
they were desperate and they tried.
No. Right. But I think that, just educate, because it is hard to, I mean, it's really hard to convince someone who loves their pellets so much to to come off the pellets. I mean, unless you tell them, you have to tell them every risk factor, and sometimes they're willing to take it. So, that's again a personal
I mean,
decision, and neither of us
yeah, it's
take
her
our own
clinical
medicine.
choice. And what happens is these clinicians are not offering them all the options. They're just only offering pellets, which is a huge red flag, and that should never happen. There's no reason you shouldn't be able to prescribe FDA approved options for your patient and allow her insurance to cover it. It's a huge moneymaker, and I just think the way that they're being utilized tends to be unethical, and patients are suffering because of it.
Absolutely. I mean, we have these people knocking at our offices all the time, like, "Hey, you wanna," and I'm just like, "No, you're not coming into this
No,
office." No.
no.
Um, and, uh, and so, okay, well, let's talk about also, so this book has really exploded. It's been amazing. Tell me, what when did you decide to write this book, after the Galveston diet? You said that, when was it with the research? Tell me about.
So we turned in the manuscript for Galveston Diet. So Galveston Diet was published in January of 2023. And I think I turned in the manuscript the summer before. It takes months from when you turn it into when it's published. It's a very long process.
Yeah.
And so we were up here in
Yeah.
Colorado. So I'm in Colorado right now. We were hiking. And my husband and I did this like 2-hour hike, and we were talking. And he's like, it sounds like you need to write a book about menopause, and I was wanting to get away from the diet nomenclature and the diet culture.
Sure.
And, I knew I
Right.
had a bigger message. And he's like, you need to write
Yeah.
this book. And I remember as soon as we got home, I got on the phone with my editor and said, I really want to write a bigger book about menopause. She says, well, how would it be different than Galveston Diet? I'm like, oh my God, you have no idea. And so that began the process 2 years ago this summer. And so I wrote the book here in Colorado. I took 3 months off last summer doing the research and working with the editors and my collaborator, really refining it. And so just the best thing I've ever done, just the hardest I've ever worked, all the hundreds, thousands of articles I read, trying to make sure I fully grasped what was in the literature so I could share it with the world.
Yeah, no, and it's so nicely put together, and it's like, very. I think everyone's that I've spoken to that's read it, because I have a lot of patients that come in with this book and like, well, I've read Dr. Mary Claire's book, and I'm like, oh, okay, so you know exactly what you want. I mean, it makes life a lot easier as a clinician.
Yeah.
They're already like, well, like, look at my symptom list, Dr. Rahman. Like, because you have the little area where you can write your symptoms, and I'm like, oh, very nice. Okay, so I think that, in that respect, it's been wonderful. You've gotten a lot of good feedback from people doing it in clubs, like book clubs and everything, right?
Mm-hmm. Yeah, it's been really amazing. We've hit the the big one, the New York Times bestseller list for 6 weeks now. We haven't missed it yet, and that's kind of a marker of how you're doing. We're always in the top 50 on Amazon. And some days I have to pinch myself, like, wow, like it's beyond like my social media presence now. Like the book is being shared and people are telling their girlfriends and they're having book clubs and it's got legs, as they say. So, and that's really what I wanted. I wanted this to be a tool that women, females could use to advocate for themselves and educate themselves to have a better, healthier life.
Absolutely. Are you going to do into different languages? Because I'm sure it's like, internationally needed.
Yeah.
Well,
So the editor does all that. Like I don't own the book, the publisher does. So they've sold it. Oh God, Lithuanian, Croatian. We're waiting on Spanish. We have German, and we're waiting on Japanese. I think we did Chinese. So yeah, it'll be like 18 languages so far.
oh, wonderful. Wow, that's amazing. Um, what what are the things that you offer your, like, when a patient, because are you still seeing patients right now, or are you kind of taking a break?
Mhm. Well, right now I'm taking a break,
Oh,
but my clinic's still running. I have 2 nurse practitioners, so we communicate. So they're seeing patients right now.
oh, okay, great. So, what are the things that you tell? So, we should just talk to the discuss with the our listeners so that they know, that well, basically, I want to ask what you tell your patients, like when they come in to see you, and you and I practice precision medicine, so everything we do is geared toward that specific patient. But how do you approach your
Mhm.
patients in the office?
So luckily, I have a body scanner in my office where I
Oh,
can measure visceral fat, muscle mass, and her, besides just weight or BMI. So a lot of the discussion we have is around her body composition and what that means to her health in future. So if they have low muscle mass, we're talking about ways to improve that will also improve her bone density. If she's got high visceral fat, then we're looking at certain nutritional exercise, tools to get that down to decrease her risk of hypertension, diabetes, and stroke. And then, of course, we have a conversation around hormone therapy and other pharmacology. So I have an hour with my patients, and I give her a comprehensive, plan: nutrition, exercise, stress reduction, sleep optimization, community, how important it is to talk about this, as well as their pharmacology.
Yeah, no, that's great. Do you think you're going to do another book after this? I don't know what you'd write on.
Yeah, I've already negotiated for the new Perimenopause. So really, really, really blowing out the new Perimenopause. And then in my dream, I have a third one, which is the postmenopause, like really honing in on the behaviors and things like once your symptoms are gone that are going to keep you healthy and out of a nursing home.
I've been asking all the other people I've interviewed as well, because, now most of us get like those, mid 60 or close to 70-year-old patients who, like, for instance, I've been seeing for GSM or, whatever urinary stuff. And they're like, we feel left out of this equation because, 20 years ago when I entered menopause, the doctor told me I couldn't be on systemic hormones. Like, is there a chance for me? So tell us how you approach those patients.
100% she needs vaginal estrogen if she has a vagina and she's over the age of 60, that is a non-negotiable. So yeah, hormones are for her. As far as systemic, if she's gone without hormones for more than 10 years and she's over 60, she's probably lost most of the cardiovascular protective benefits. And it won't hurt her, but so we start talking about cardiovascular risks and symptoms. I sometimes get a calcium cardiac score to check for atherosclerotic disease, because if they do have severe atherosclerotic disease, HRT, estrogen might make it worse. Again, there's some controversy there, but I'm wanting to get the fuller picture of what we're looking at down there.
Sure.
And, there is a window of opportunity for brain protection as well. So I can't tell her this is going to decrease your risk of dementia or Alzheimer's, only when she's younger, or earlier in her menopause journey would that appear to be protective. So estrogen is better at prevention than cure. 100% is going to protect her bones. 100%, always, every day for the rest of her life, always protecting her genital urinary system. And I'm giving it to her both ways, systemically and vaginally. I want to hit it from both ends because the data of, how many women end up in long-term care facilities or in hospitals from urosepsis. And that is 50% preventable with just vaginal estrogen, prophylactic vaginal estrogen. It should be in the water. So those are the things I counsel about.
Yeah, that's what my favorite thing to say is that vaginal estrogen is life-saving because of that. The urosepsis leading to 6 of them die from urosepsis when they're hospitalized. So, I mean, it's life-saving. So, most of my listeners have heard me say that many times. Okay, so you're going to do your next book probably. Let's talk about, when you talk about, just a little bit more about the weight management portion, because I haven't had that many people discuss the best ways that they introduce weight management for their patients. So you do these body scanners. Tell me where you talk about what things that you would bring into the equation for your patients.
So we try to make sure she's getting adequate protein to support her muscle mass, or if she needs to grow muscle, I'm recommending more. So I'm giving her grams per day of protein, fats, and carbohydrates, just rough, within 10% goals. I do put them, knowing what her basal metabolic rate is, because I have that scanner, I am putting her in a slight caloric deficit, but nothing crazy, because I want her to get adequate nutrition. And we're going to rely on movement to try to, keep that calorie deficit going. If she's on the couch, we talk about walking. If she's walking, we're going to put on a weighted vest. If she's already weighted vesting or doing light weights, we're going to go for heavier weights. You have to meet the patients where they are. And not so much focusing on that number on the scale. We're focusing on hanging on to this muscle mass while we lose the fat. The most difficult patients are the ones who are skinny, who have low muscle mass and high fat, because it's hard to do that both at the same time, to build muscle while you lose the fat. It just, the two are just diametrically opposed, and people freak out on the scale. So we kind of pick one and fix that first. Then we go to the other. Unfortunately, the pressure from our, cosmetic society is to look a certain way and whatever, but that doesn't necessarily line up with her living a long, healthy life. So I try to keep them focused on that. So we talk about nutrition, anti-inflammatory nutrition. We have meal plans and things that we've developed through Galveston Diet that we send them home with. And then we bring them back to measure their body composition when they come back.
Oh, that's wonderful. Because you have all those good recipes too on your website,
Mm-hmm.
right? Awesome.
Mm-hmm.
And so then you'll just assist them through that process, which is wonderful. Tell me what you're going to do in the next 2 years, you think, other than write this book. Is there anything else that you're...
So I'd like to expand our clinic a little bit, hire a couple more practitioners because we're just booked out forever. I'd like to write the new book. So in 2026, I want to publish the new Perimenopause. I'll be 58. And so, before 60, we've developed, I'm an entrepreneur and we've developed our supplement company and we have meals through Galveston Diet. Like we've done really well with our ancillary products associated with what we do. I really want my website to be the go-to website, like the Goop of menopause with evidence, without the problems with Goop. And she's an incredible businesswoman, so I have to respect her for that. But I want this to be where people go to find information, to find a doctor, and then the last thing I'm doing at the end of this year is I'm developing a training program for clinicians to do menopause care. I just feel I want to be part of the solution, which is getting boots on the ground. So yeah, I've gotten, we've hired a CEO for that company. It's a whole separate company. And I've gotten the first time I've ever used funding. Like we built everything from scratch on our own. My husband and I have just used our personal finances to fund everything. This is the first time I'm bringing in help, in the form of venture capital to launch that business. So yeah. And it takes a lot of the work off of me. My team is going 100 miles an hour, just trying to keep my balls in the air.
Yeah. That's awesome. I love what you're doing. Okay. So when you have a patient who a lot of my listeners, will say that, they've been gaslit by their clinician. They're, not getting what they need. My tagline for my podcast, I'm here to educate so you can advocate. But how would you tell a patient to advocate for themselves other than, knowing the information you've given, or, how do you tell a patient to talk to a clinician that's not listening to them?
So, I can't fix an asshole. And so, and a lot of these doctors just don't have time in their busy schedules to get up to speed on menopause. So before you hit the door, call ahead. Are they willing to have a conversation with me about menopause? Does he or she even prescribe HRT? And if the answer is a categorical no, then this is not an appointment you want to have. Try to find someone who's certified by the Menopause Society, which isn't perfect. Or, we have lists, or go to telemedicine so that that there are people here who are you have to step out of the box to be an informed menopause provider.
Yeah. I mean, I always say to patients too, like if you're going to an OB-GYN, for instance, and there's only pregnant women in the room, it's less likely, because when I don't know if you ever worked for a big center, but when I used to work for a big academic center and I was doing both OB and GYN, you're seeing 30 plus patients a day, right? You don't want to
oh yeah.
And so you don't have that. It's always
running back and forth to labor and delivery in the middle of the day.
Yeah. So you're going to come in there and tell a patient, your doctor, all these problems, and they're going to be like, they want to stab themselves in the eye because they can't. Number one, they don't have the time to help you. They're under a crunch. So I don't, I don't speak negatively about them in that respect, but at least tell the patient, hey, you know what, this is not my area. Let me tell you who can help you, or give them the tools they need, right? Because it's not fair to the patient. But I've been in that clinical scenario where and I still feel bad about it. It's 15 years ago when I'd see a patient in a 30 patient a day practice, and someone complained to me about, sexual pain or, some sort of thing as I'm leaving the door, and I'd be like,
right.
And I still feel so sad that I did that. But I was you're in a situation where you couldn't it's not built for that. Our medical system is broken.
It's not built for that.
Mm-hmm. Yeah. Especially, for midlife women, for women who have sexual pain or, complicated histories, you need the time. You need that hour with them. You need to be able to do a full exam. But so what else do you want to tell the viewers? I mean, the listeners. I say viewers because I have a YouTube channel. What else do you want to tell the listeners before we?
kind of my, menopause is inevitable, but suffering is not. And expecting to suffer and accepting suffering is just not anything you have to do. But it is going to take some legwork, and you're going to need to educate yourself in order to have the best outcome.
And I like what you say all the time, that you have a nursing home prevention program. I think Dr. Malone, Sharon Malone, says that she wants to be a benefactor, not a burden. But it's the same concept, right?
Mm-hmm.
Your nursing home
Right. And
prevention
I
program.
love the way Sharon phrases that. And I've borrowed that phrase several times. I have 2 daughters, 20 and 23. And I can't tell you the drama in my family group chat over my mother right now and her end of life stuff. And I want to limit that as much as possible for my kids. Again, I want to be a benefactor of them and not a burden, or for as little as possible. I don't expect to live forever. And I know I'm going to have illness, but it is much the impact taking that away from them as I can.
Right. And I think that, we want to live good quality lives. We want to live, if we were to live a long life, we want to live it in a good way. We don't want to be, like you said, the nurse
to 100 with 10 of that being in a bed, no, thank you.
Yeah, exactly. No, thanks. Exactly. And we've all, I think, at some point, because we're in that midlife period where you've had enough family members with dementia or something, and you see the toll it has on the family too, right? Like, a lot of times dementia patients don't know what they're doing, but like, it plays a role. It puts a toll on a lot of family members too, just because their personalities change. And, they have frontal lobe disease, all this stuff. So, but I think that's a good ending point for us, is that we should all work to be like, really preventing our own, or just encouraging our own healthy lifestyle, so that we live very healthy and good lives without being like you said, like in the bed peeing on ourselves, not knowing where we are.
Yeah. That's it.
Absolutely.
Exactly.
Well, thank you. Yeah. Thanks so much, Mary Claire. I appreciate you being here today. You are amazing. You are a force to reckon with. I love being part of the menopause. Thank you for all that you're doing to help the world, really. I mean, I think it's amazing. So I'm going to put all your stuff in the show notes, and, how people can get in touch with you. And the new Menopause, if you haven't bought it, is available on many platforms, but you can get it in bookstores and Amazon and anywhere you get books, pretty much. And you can find Dr. Merrick on many platforms these days. So, all right.
Thank you.
Thank you so much. This ends another great podcast for Gyno Girl Presents Sex, Drugs, and Hormones. I'm here to educate so you can advocate for yourself. Please join me for my next podcast, and enjoy your day. Thank you so much. Have a second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.